it sort of moves us on to Germany and Austria. And, what's wrong with that? What's wrong with with segregating unvaccinated people who are a burden on their health systems? And are they more likely to transmit disease to others and cause more pressure?
Well, again, I think we need to move away from this question of vaccinated versus unvaccinated. And what we need to understand is what is the level of antibodies in the population as a whole. And I've actually not seen any data on that in these discussions, because the critical thing is the level of population immunity, however it's acquired. And if the unvaccinated have had high levels of infection, then requiring them to be vaccinated doesn't really achieve very much, apart from, obviously a loss of goodwill between a significant number of citizens and the government.
Sorry, yeah.
And I mean, the German-speaking world does have a particular issue in that, for all its technical achievements, Germany, Austria, to some extent, German-speaking Switzerland. I mean, the brilliant biomedical science, German-speaking Switzerland is at the heart of a lot of the pharmaceutical industry. But these are also the homes of an awful lot of natural medicine. Veganism, vegetarianism. I mean, naturopathy, herbal medicines of various kinds. I mean, these things are very strongly rooted in the medical, the cultural traditions of those countries, and that, I think, has been a problem in persuading people to accept vaccines. I think there have also, I suspect, been issues about the degree of outreach into the sizable ethnic minority populations, which, again, those countries have been reluctant to acknowledge. It's only relatively recently that Germany, for example, has come to accept that its large Turkish minorities are not sort of guest workers in the phrase of the 1950s, but they're a permanent and settled element of German society. And I would not be surprised. I have no direct evidence on this, but if there weren't actually problems in delivering public health services into those communities, if the agencies of the state have been a bit slow to develop an appropriate relationship with them.
So it wouldn't be something that you would advocate, just sort of to try and encourage vaccination uptake and segregation in that way, and why not?
Well, essentially, vaccination protects the vaccinated. I mean, the unvaccinated are more likely to end up in hospital. They are more likely to end up in intensive care if you look at the risks as opposed to the numbers.
Are they more likely to transmit, or is the jury still a bit out on that?
It's not clear that they are more likely to transmit, but if they are more likely to be infected, then there are more opportunities for them to transmit. But you could be in a room with people who are vaccinated and transmitting. You could be in a room with unvaccinated people who are transmitting. But your vaccine status is what protects you from anything other than a mild infection in either case. It does look as if, yes, if you have been vaccinated, you may recover more quickly, so you may be infectious for a shorter period. So, I mean, there are benefits, but they're not dramatic benefits.
It depends what data you look at. I think with the Delta variant, there was a really tight call, wasn't it? I think the Lancet had 23 and 26% chance of vaccinating in unvaccinated and vaccinated groups, a small margin.
Well, I think this is part of the problem that, many of the things we're dealing with have do have these small margins. I mean, a lot of the so-called non-pharmaceutical interventions, it's very much the same. There's small margins and a lot of uncertainty. and a reluctance to ask questions about whether those margins are so small that they're cancelled out by other factors, factors other than biomedical ones.
So on non-pharmaceutical interventions, do we now have a better idea of what works and what doesn't? And surely the data is in. I noticed there was a recent paper in one main national newspaper saying masks were stopped 53% of infections, something like that.
Well, that was a claim which was being sort of shopped around fairly aggressively by the British Medical Journal. What I liked was the sort of tweet from John Byrne Murdoch, who's been covering this area for the Financial Times, who said, anybody who retweets it obviously hasn't taken the trouble to understand the science behind it, or, as I would add, has actually looked at the issue of the BMJ and recognise that there's an editorial in the same issue that is effectively rubbishes the study. And there's a very good dissection of it, again, on Twitter, although I hope you'll write it up, by Ben Cowling, who's a professor of epidemiology in Hong Kong, who's actually gone back to the original studies from which the meta-analysis was done, found various significant misrepresentations and strange weightings. The interesting thing is Cowling is essentially an advocate for masks, and is saying, well, look, our case is not served by this kind of exaggeration.
So do we know we've got masks, distancing, I'll come back to that in a minute, but do we know what measures work, and would we have been better sort of investing in money in the NHS instead of some of the measures that we used?
Well, the best evidence that we have, and it's still not very good, is from the randomized controlled trials of masks. And the best of it is a trial that was done in Bangladesh, which achieved a reduction of 8.6% to 7.9% infections between the control villages that did not wear masks and the study villages wearing cloth masks. If they had surgical masks, it was comparing 8.6 to 7.5%. So what we're talking about, although it's been widely touted as a 10% reduction, what you've got is a 10% reduction on a very small number. And where there are sufficient margins of uncertainty and confounding factors in the trial itself, to be very uncertain of that figure. So I think personally I'm of the view that at most masks make a 10% difference, but they may not even make cloth masks make rather less than that, and they may well the benefits may well be outweighed by the the other problems that they give rise to,
such as,
well, clearly they stigmatize and discriminate against quite large sections of the adult population who have communication issues, autism issues, people who've experienced trauma from rape or other assaults, or from terrorism. There are the impacts on small children and language learning, the importance of seeing lip movements to be able to learn to speak a language properly. The latter, it seems to be a well-established field in linguistics and education, but I've not seen anybody think it was worth doing a systematic review to inject the data into the masks debate. So we are looking at, again, as I was saying a few moments ago, we're looking at these sort of small and uncertain gains, which may not be worth the cost. And given that, we should be, we should be able to stop doing them without dramatic results.
It brings me to, I think you're one of the main people, or the person who sort of work in the area of the 2 meter rule led to the government sort of revising that down. And I think they brought in a 1 meter plus rule. And I know today there's been a report showing that the 2 meter rule was, you worked on that over a year ago, didn't you? the 2 meter rule was in fact arbitrary, and it wasn't really a game changer. 2 meters, 1 meter plus. I mean, social distancing, do we have good data on that? It seems logical that if you stand far enough away from someone, you're less likely to catch an infection from them. Do you not think that's logical?
Well, there is a certain logic to it, and as various people have pointed out, it's a continuum, and it depends on when you cut into it. To say, okay, here's the line, and we come back to this question of the tolerability of the risk. And clearly, the risk increases as you get closer. But what the scientific analysis has really failed to take account of is the social science work in a field called proxemics, which has been around since the 1950s, and it is the social science of social distancing. Now, you could read all the SAGE reports and not realize that this exists. And what it says basically is there's a little bit of cultural variation from one place to another, but humans do not like to get much closer than a meter to people that they don't know really well. So, in a sense, having a social distancing rule is a bit redundant, especially if you are part of the sort of droplet school. You're focusing on the sort of heavier particles that people breathe out. Those droplets rarely travel as much as a half a meter. So at a 1 meter distance, you're very unlikely to be breathing anybody else's air.
Right.
So, of course, the people who are closest to you are the people that you let come closer than your children, your partners, your lovers, whatever. And what we know is, of course, that households are the primary place where transmission occurs, because you can't regulate those. I mean, you're not going to go home and wear a mask yourself and make your kids wear a mask just so that just in case you get a bit close to each other, are you?
I think in some states in America they are mandating masks indoors now, so it just depends on the area. Yeah, but I mean, you're a sociologist or medical sociologist. Some people would say, why is it important to have a sociologist? Is it important? Do we not need virologists and epidemiologists who understand disease?
Well, of course we need virologists and epidemiologists. And I'm not an anti-science person. I've got a great respect for the science, for the scientific work that has been done in the course of the pandemic. But the science does not translate into societal action, into public policy in any simple and automatic way. And you describe as a medical sociologist. Also in the last 20 years, so I would suppose would describe themselves as much as being a sociologist of science and technology. And one of the things you realize is that the science is there and it's important and it's interesting, but what we do with it is not determined by the science. It's determined by the way in which that science gets into society and the way in which the science is shaped by a great variety of social and institutional factors. So if we take the example of proxemics, that doesn't get in because it's never been a subject of relevance to the medical world. The people who are really excited about it are architects, transport planners, and people designing factories where humans have to collaborate with robots. And you need to program the robots so they don't get too close to the humans and frighten them. And understanding this is really important.
How would it have helped can you think of examples in our response to the pandemic where we could have really referred to more sociologists? For example, we had 6 people allowed at a restaurant when, there are people who have maybe a number of children that they can't, share with friends or neighbours to look after while they went to work. I mean, do you think it was important during the lockdowns for your voices to be heard?
Well, indeed. I mean, I've been looking at a paper that's coming out later this week for the Science Media Centre which is using mobile phone data to look at the amount of home visiting that was going on during official lockdown periods. And it's quite interesting how much more of it was going on than anybody thought. especially as sort of time went on and people made their own assessments of the tolerability of risk. But we've never understood the drivers for that. We've never tried to look at them, and it's this study itself isn't capable of throwing any light on that, apart from suggesting that there are patterns that need to be understood, and that, if you like, lockdown fatigue is probably as complicated a phenomenon as vaccine hesitancy, and that it's not dealt with by more rules, harsher rules, more enforcement. It's dealt with by understanding the important reasons why people get together. What is it about us being social beings? What is it about the networks that we live in, the networks of relationships around us, the obligations that go with that, and how does the public health world work with the grain of society, rather than constantly trying to cut across it and say the rational thing to do is X, therefore we must have a rule that compels people to do X, and that means that we must have people go around and enforce it. I was interested in a report this week from Northern Ireland about an argument between the Health Ministry and the Justice Ministry, where the Health Ministry were wanting tighter restrictions over the next month or so, and the Justice Ministry was saying, well, we don't want to enforce them because, as you can imagine, in the delicate situation of Northern Ireland, police-community relations are really important.
Mm.
The ministry responsible for policing has to think very carefully about what it means for a community, to be restricted in this way. And what seems obvious to the health ministry is not obvious to the justice ministry, or potentially causes all sorts of problems for them. And that's the sort of joined up thinking that I would have hoped a greater involvement by sociologists, people who study institutions and organizations more generally, could have brought.
We have a similar situation here where we have directors of public health imposing restrictions on schools and school children. Masks and isolation of kids is still going on, even though in the adult world it's not. And then we have the Department for Education saying something quite different about the need and the importance of in-person learning for children. And there seems to be a bit of a mess because of this lack of joined up thinking. And indeed, across the country, we have a big polarization. And I know that when the government did come to Freedom Day, when we did open up and delayed by a month, we still went ahead with opening up. And then 1,200 scientists wrote to the Lancet to complain and said it was a dangerous and unethical experiment. So we've got, a huge voice saying that we need more restrictions. Can you say that you think they were wrong to say that? And in hindsight, do you think they were?
Well, I think they were wrong to assume that they had the right to demand that. I think there is clearly, and again, this is very much an issue in sociology, anthropology, and the sciences that study culture, about what we understand by infection. Now, I had the privilege of working for about 13 years as an advisor on Science and Society to the Biological and Biosciences Research Council, which funds biological science in this country. The Medical Research Council funds biomedical science. But I was working with biologists. Now, biologists just study interactions between organisms. They don't make judgments about those interactions. And they've got a language which is morally neutral. They talk about commensals, which are organisms that operate side by side, but don't really get in each other's way. They talk about parasitism, where one organism takes resources from another and may ultimately damage that organism, but parasitism is a neutral way of describing it. and there's also the word escapes me for the moment, but there's a third, which is where one organism, where the organisms sort of mutually reinforce each other.
Yes.
So you could say, if you were studying the sort of gut bacteria of humans, that the bacteria that are in your bowel, you may not like to think about it, but they don't really do any harm most of the time. But they help to sort of process food into forms that can be absorbed by the human body. So we benefit, our bodies benefit them, and they benefit us, and you've got this kind of mutual benefit. And that terms like infection and disease are morally loaded terms. Medicine is a moral enterprise in that sense. It is about making value judgments about the relationships between organisms. In this case, humans and the various other organisms in their environment, like viruses and bacteria. There's nothing inherently good or bad about a virus or a bacteria. It doesn't have agency, it doesn't have intention, it doesn't set out to do harm to us. It just tries to exist. And it's us who puts the judgment on, we don't like this, and we're going to do something about it.